In terms of the outcomes of older patients treated in the pivotal and landmark ECHELON-1 study, there is published data to this end. Of course, this was a more than 1,000 patient worldwide study, and as expected, the majority of patients were younger. However, approximately 15% of patients treated on ECHELON-1 were ages 60 and above, which to me really almost labels it and represents a real-world analysis, in that in population-based studies, 15 to 20% of patients are older, over the age of 60 years. And we know in many prior clinical trials, it has been a very underrepresented, typically 5% or less. And so in ECHELON-1, 186 patients were ages 60 and above. So it was a pretty large cohort, really one of the largest in a prospective cohort in the modern era to analyze older patients. Now, not surprisingly, outcomes were inferior for older patients compared with younger patients. That was one analysis that we had. And when we look at that data, generally speaking, at 5 years, for patients treated on AAVD, the 5-year outcome for older patients was 67%, while for younger patients treated with AAVD, it was 84%. So that was one glimpse at the data, looking at younger versus older. But we also had the opportunity to look within the older patient group between AAVD and ABVD. Now, the AAVD is given concurrently, so we know there can be some challenges a little bit in terms of tolerability that I'll highlight in a minute. But generally speaking, and partly probably because of the number of patients, it wasn't significant, but there at least was a numerical advantage to AAVD in older patients of 67.1% at 5 years, compared to 61.6% of older patients treated with ABVD. Now, we don't think of treatment-related mortality, but you can see this, and this is where there's always caution, not just in older patients with Hodgkin lymphoma, but any hematologic malignancy. There were fatal adverse events of 4 to 5% seen in both arms. And so that's always a note of caution, why I think not only of a pre-phase, but maximum supportive cares, make sure to see these patients every 2 weeks, face-to-face, et cetera. In terms of discrete tolerability, febrile neutropenia was higher in older patients with AAVD at 37% versus 17% with ABVD. Conversely, serious pulmonary adverse events were more common with ABVD at 13% versus 2%. And also, not surprisingly, peripheral neuropathy was increased slightly with AAVD, but also we saw it with ABVD. That's what I liked about this study, is we got report outs of peripheral neuropathy objective assessments with ABVD. So when we looked at grade 2 peripheral neuropathy, it was 19% AAVD and 13% with ABVD in older patients. Those numbers are for older patients. And remember, grade 2 is significant when it at least respect to peripheral neuropathy. That means it's impacting adversely instrumental ADLs, cooking, managing money, shopping, et cetera. So something that I think obviously we need to pay great attention to, tolerability and peripheral neuropathy in all patients, and especially the older patients. But nonetheless, a good data set for us to build off of. And just one last point of reference is in our ongoing, actually, we recently completed accrual S1826, North American Advanced Stage Study, where the standard of care arm in this study is ECHELON-1, AAVD, and the experimental arm is Nivo-AVD. Approximately 1,000 patients enrolled, of which 10% are older. So we'll look at not only more output and data with AAVD in older patients, but a comparison between a checkpoint inhibitor and frontline therapy.